this was a femoral shaft malunion. What seems as a nonunion is only that break on the lateral cortex. Rest of it is all united. This was in varus, procurvatum, and there was an apparent shortening. So clinically there was right now no signs of infection, no sinus. CRP was normal. And this was the axis, proximal and distal. So the surgical plan was using LRS. So as per the plan, whatever the proximal axis we had decided, the shank screws were applied perpendicular to that, then to the distal axis. That's what was seen on the lateral view. To correct the procurvatum, the orientation of the shank screws was this along the shaft. This is, and the osteotomy was not planned at the malunion area to avoid issues with healing. Therefore, that resulted in a little bit of translation. Correction of angulation, a micrometric swivel clamp was used, but this was an acute correction done on table. The swivel clamp was used in case we need to fine tune any of the angulation later on after a full length. But overall, everything was well aligned, and since it was an acute correction and in compression, patient was allowed to weight bear with that. Went on to uneventful healing. If it's a non-union, yes, the same way earlier, like the plan was, you would need to refresh the edges, excise all the fibrous tissue from there. And the main thing with the non-union, with a stiff non-union especially, is realignment. Once the alignment is corrected and it's in compression, it will heal. Patient was explained that he will have some shortening remaining, and if needed, then he can go in for a lengthening at a second stage. But at the end, he had only about a 1.5 centimeter shortening, which he was happy to use a shoe raise.